Hey everybody, welcome back to part two. Last class we covered those glands can be found in the head, hypothalamus, pituitary axis, and pineal gland. We are going to start today with the glands that can be found in the area or region of the neck. Okay, these glands, thyroid gland and parathyroid gland, important here two things: calcium and the thyroid hormones, of course. So we're going to review those in detail now. So based on the region, this is primarily your strategy for to be able to localize and found these glands. In the neck, you have just two options, right? Thyroid gland and parathyroid glands. Parathyroid glands, they're going to be in the back of the thyroid gland. So what we have here is just a fraction, just a part of the respiratory system, right? This bone from AMP1 is called the hyoid bone. It's the bone that we have in the neck, and it's a floating bone. There's not another bone connected to that one. Right below that, we have this cartilage. Right, this is what is commonly referred as the Adam's apple. Other people sometimes call this like the vocal voice, um, uh, the vocal voice box, or just vocal box. The name is the larynx, okay? So the larynx. Below the larynx is the place where we have the thyroid gland. Now, this is a representation of the whole thyroid gland, right? It has two lobules and has an isthmus, which is a part that connects one lobule with the other one. Um, Remember that in anatomy, sometimes you're going to see some structures and sometimes you're not going to see structures. This thyroid gland is covered by, sometimes you will see it, is covered by muscles. It goes here, so you might not see the whole gland, right? But just keep in mind the location. Also, you're going to learn that it's kind of between or on top of the beginning of the trachea. That's where the thyroid gland is located. All right, let's look at some of the major functions here. Okay, let's start with the thyroid gland. Thyroid gland, I want you to remember that it produces two hormones. Of course, the most important is thyroid hormones. That's why the students always remember this and forget about the second one, which is calcitonin. Okay. Now, calcitonin is important because this, with the parathyroid gland, those are the two glands that will regulate your calcium levels in blood. Calcitonin, the main function is to reduce calcium levels in blood, of course, when the calcium levels goes up. If something happens in your body that it causes hypercalcemia, which is the medical term, to compensate that, the parafollicular cells, which is a group of cells that can be found in the thyroid gland, those are the ones that produce calcitonin to bring your calcium levels um, back to the normal, right? So it reduces calcium levels in blood. Now the thyroid hormones T3 and T4. This is most of the time the way how we talk about them. We're gonna see the names, but this number 3 and 4 we will learn that has to do with a crucial element or atom that forms or is part of the chemical structure of these hormones. Now the importance here is, why do we need thyroid hormones, right? Why the thyroid hormones are important. So they're important because those are the hormones that maintain your basal metabolic rate. What does that mean? Is the amount of energy that your body uses at rest, and it's basically the metabolic rate is the ability um, of the body to obtain energy from food. Is the ability of your body to create ATP or create energy, to generate heat. So think about these metabolic hormones that are the ones that keep you moving, keep you active, keep your body, your cells, your tissue active. When you have lack of thyroid hormones, everything, as you will see with the symptoms, everything will become slow, and the opposite is true with high thyroid levels. Everything becomes way too active, hyperactive, and high. Okay, so these thyroid hormones definitely important. Can we survive? Can we live without thyroid gland? What do you think? Is is it possible to live without thyroid gland? The answer is yes, right? And that's why I say before you need to become an expert in thyroid gland because it's something that is very common. Many people have problems with the thyroid. Many people have not a thyroid gland, so they remove the thyroid because they have a cancer or because they have an immune system that was causing problems with the thyroid. And people who has that do not have a thyroid gland because it's been removed, they need to take thyroid medicine replacement. Okay, so um, yes, you can live without your thyroid gland, but that means that you will be taking thyroid medicine for the rest of your life. Um, Thyroid gland also and thyroid hormones are important during pregnancy, especially for the baby, because an important part for the development of the nervous system in a baby is thyroid glands. So we're going to see in the disorders in just a minute that when the thyroid hormones are reduced during pregnancy, that will affect the baby and the childhood development permanently. So it's very important to make sure that if to make sure that the female when she's pregnant that her thyroid levels are in the normal range. So we described the location of the thyroid gland. Basically, the thyroid gland is in your neck. It's interior, again, and on top of the trachea, just below or inferior to the larynx. We talked about that already. The important part of the thyroid gland is when we look at the thyroid gland under the microscope, like this picture that we have here, we need to realize that there are two types of epithelial cells, or in other words, there are two types of cells that produce different things. As you know at this point, the thyroid gland produces two hormones, calcitonin thyroid thyroid hormones. So we have the cells that are called the follicle cells, right, or follicular cells. Those are the cells that are related to the production of thyroid hormones. Okay. Now we also have parafollicular cells, and these parafollicular cells, para means besides or in parallel. So these are the ones that produce calcitonin, right? The ones that we use to reduce calcium levels. Now, between them or in the thyroid tissue, we have this space that is like a capsule, is completely filled with a fluid. This fluid is called colloid. Okay, colloid. So this colloid contains essentially all the ingredients, right, there are going to be required to produce and synthesize thyroid hormones. The most important component that you need to know for your exams is iodine. Okay? So without iodine, we cannot synthesize thyroid hormones. In fact, when you see the reduced version of the thyroid hormones, when I say reduced version of abbreviation, you're going to see that which is called T3 and T4, right? So the number 3 and the number 4 reflect the amount of iodine uh, atoms that you can see in the chemical structure. So T3 contains 3 iodines, while T4 contains 4. Okay, we're going to cover these briefly. So uh, we need to get our iodine through our diet. Our body is unable to synthesize iodine, so we need to ingest iodine. There are regions in the world where iodine deficiency is common. Naturally, we have iodine in things like seafood, and now in developed countries, they add iodine with the common table salt, right, to prevent iodine deficiency. Anyways, iodine is absorbed through the diet, then is transported through the bloodstream, and the thyroid gland is like a sponge that is the one that collect this iodine and it stores that iodine in the colloid, right? The iodine then will have several chemical reactions whenever it's necessary to create the thyroid hormones. Now, all these details, I'm going to let you choose to read about it, okay? But what you need to know is the name of the hormones. T3 is thri, that means 3, iod, okay, iod, thiodenine, 3-iod thiodenine is T3, and T4 is thyroxine. Again, the number 3 and 4 reflects the amount of iodine atoms in the chemical structure. Now, your thyroid gland produces way more T4 than T3, but the active hormone, the one that your tissues is going to use, is T3. So again, for example, if you do a blood test, the thyroid hormone produces way more T4, and T4 is what circulates in your blood in largest quantities if you compare that against T3. However, once the T4 arrive to the tissues, to your organs, then in your tissues is converted into T3. This is the active, and T3 target the mitochondria, which from AMP1, I hope you remember, mitochondria is the powerhouse, is the organelle of the cell that is in charge to generate energy. Okay, now we reviewed this before. Your thyroid gland will not release or produce any thyroid hormones without TSH. Okay, so TSH is the way how you tell your thyroid gland, please produce and release thyroid hormones. Okay, so this, what that means is that also the levels in your blood of T3 and T4 are the ones that maintain, are crucial to maintain the negative feedback loop, to maintain homeostasis. What does that mean? That if your T3 and T4 levels are high, your hypothalamus will do something about it to, if it's high, to bring it down. If it's too low, to bring it up. So this is what we call the negative feedback loop. And again, it gets kind of complex because there are three parts. It's like a cascade, right? That's what it's called, the hypothalamic pituitary axis. So when the levels of thyroid hormones, for example, go too high, right? If we have too much thyroid hormone, T3 and T4, that stimulates the hypothalamus to, sorry, I should put it here, to the hypothalamus to stop producing the hormones that eventually will stimulate the thyroid gland to release thyroid hormones. And the same is the same in the case of if your thyroid levels are too low, let's say T3 and T4, they're for some reason, if they're too low, your hypothalamus, that is the stimulus, that low levels of thyroid hormones trigger the production in the hypothalamus of this hormone, TRH, which I told you, don't memorize that. Don't worry about the hormones produced by the hypothalamus. But basically, all of them releasing hormone, RH at the end. This thyrotropic releasing hormone is the one that stimulates the interior pituitary gland, specifically to produce TSH, and TSH is the one that stimulates the thyroid gland to produce the thyroid hormones to compensate, to try to bring the thyroid levels back up. So that's the basic concept. Now let's cover the main disorders associated with the thyroid gland. And basically, when we think about thyroid gland, there are two things that you need to know. The disorders can be related that we have too much, right? Too much T3 and T4, or that we are deficient, that we have too few, that we don't have enough T3 and T4. When we don't have enough, we always of something, we always call that hypo, right? And we have too much, we call that hyper, like hypertension, hypoglycemia, hypernatremia, hypothyroidism. So that means low levels of thyroid hormones, and hyperthyroidism, high levels. Now, hypothyroidism is, there's many subtypes, or there are many causes that can cause hypothyroidism, right? So what is it? Low levels of thyroid hormones. What will be the symptoms? And that is what you need to keep in your head for your exams. Most likely in your exams, the way how you're going to be asked is, you're going to have a patient with some symptoms, and the symptoms should, lead you to think about thyroid hormones. So hypothyroidism, basically low metabolic rate. So that means everything will slow down. If you think about the intestines, what happens with the intestines when they're not actively contracting and moving, uh, whatever they have, the food or the content they have. They move slow, right? That cause constipation. So that's one of the symptoms people might refer, have constipation, dry skin, this, weight gain, of course, because with a low metabolic rate, uh, all your tissues, mitochondria, are very slow. So even to burn calories, so you're going to start gaining weight. And cold in the extremities, this is related with the same thing. When you are not able to burn calories to generate heat, you're going to have cold intolerance, because every minimal changes in temperature that is below, that is getting cold, your body normally, when that happens, start generating heat. But because you're lacking of thyroid hormones, people with hypothyroidism will complain about cold intolerance. From the mental or neurological perspective, somebody with hypothyroidism, you can imagine, uh, they will have a reduced mental activity, depression. They will complain about having hard time concentrated, feeling like they have no energy, uh, reduced libido or sex drive, menstrual irregularities. So all these symptoms should make you think about low thyroid levels. Now, there's a condition or something called goiter, which goiter just describe, and be clear with this, goiter just describes the medical term that we use when the thyroid gland is increased or enlarged. Okay, so it's an enlargement of the thyroid gland. Goiter is most of the time associated, either sometimes you can have goiter, you can have an enlargement of the thyroid gland when you have a cancer, but what you need to be able to connect here is iodine deficiency. Okay, so iodine deficiency causes goiter. I have a picture here for you to see this big mass in the neck in this person. There's a massive goiter seen in patients with iodine deficiency. You might be wondering why the thyroid gland grows too much when there's a iodine deficiency in the diet. Well, I told you before that iodine is like a little sponge, right? That sucks and collect all the iodine that you have in your blood. So think about that when you have a deficiency in iodine. First, the TSH that comes from the pituitary gland is asking for thyroid hormones. It's kind of constantly stimulating the thyroid gland to produce thyroid hormones. However, the thyroid gland is unable to make them because it's lacking of iodine. And the thyroid gland, being an sponge, is trying to, it grows more and more and more with the purpose of collect any or be more efficient collecting any iodine you might have in your blood. I used to do an analogy in the class that is like you're trying to, you know, collect water with a bucket. The bigger the bucket you use, the more water you're going to collect, right? So it's kind of the same thing here. The thyroid gland is growing to try to collect any minimal iodine you have in your diet. And this other condition here, neonatal hypothyroidism, also known as cretinism, is what I mentioned before. When the mother has hypothyroidism during pregnancy, the baby will develop hypothyroidism. And I told you that the nervous system, that thyroid hormones are extremely important for the development of the developmental nervous system development. So the patient, the baby, will have uh, intellectual disabilities, cognitive disabilities or deficit, short stature, sometimes deafness, and anyways, all of these symptoms sadly are most of the time irreversible. So that's why one of the screening tests in a pregnant woman is going to be to check the thyroid levels to prevent this in the baby. So neonatal hypothyroidism or cretinism is iodine deficiency during pregnancy. Right, now let's look at the other side of the spectrum, right? So hyperthyroidism. Hyperthyroidism is an elevated or an excessive amount of thyroid hormones. Again, your goal here for your exams is to recognize the symptoms. Now, the symptoms, if you think about it, everything will be fast. Everything will be, you know, extremely accelerated. So the metabolic rate will be high. That means that your body will be burning calories. It's like you're running all the time. It's like you're doing exercise all the time. So your body will have an excessive amount of body heat. Therefore, if you always are hot, it means you become hot intolerance. So in the summer or just environmental areas where there might be a little bit raise in the temperature, you will feel like it's extremely hot, right? You'll be sweating. People develop tremors, which is shaking of the head. Like you think about somebody with anxiety or with a panic attack. With the intestine, if you think about hypothyroidism, make your intestine work slow. Hyper will make them work very fast. That translates to diarrhea. If you're burning a lot of calories, right, you're going to have weight loss, increase in heart rate. All these symptoms tells you hyperthyroidism. Now, again, hyperthyroidism, there are several causes that can affect uh, or cause hyperproduction of hormones. But the ones that you need to know for your exams, at least one of that, is again, this is not all the causes, but this condition called Graves' disease. Okay, so Graves' disease is an autoimmune disorder. Okay? So it's an autoimmune, your own immune system start to develop antibodies. So they develop antibodies that they they look like, and I'll put here this like this, they look like TSH hormone. So these antibodies that are produced in Graves' disease, they mimic TSA, thyroid stimulating hormone. So because you're having a bunch of these antibodies that are stimulating the thyroid gland over and over and over again, the thyroid gland start producing a lot of um, thyroid hormones, and there's no way you can stop that because it's not under any regulation from the hypothalamus or pituitary gland. In fact, the TSH in patients with Graves' disease, what do you think the PSH will be, high or low? We know that for sure the patient has high T3 and high T4. That's what causes the symptom of hyperthyroidism, right? So what do you think will be the level of TSH in this patient, high or low? Think about it. Okay, so the TSH will be low, right? Why? Because remember that high thyroid levels is what inhibits the hypothalamus. So the hypothalamus, um, also the level of the thyrotropin releasing hormone in the hypothalamus will be low, low and low. Now, but how come is that the TSH, T3 and T4 is high? Well, it's because it's not the pituitary gland who is stimulating the thyroid gland. In this case, are these antibodies that comes from your immune systems, the ones that are stimulating the thyroid gland. Okay, so that's why these ones T3 and T4 will be elevated while the TSH will be low. Anyways, what you need to know is specifically for your exam, specifically this disease, Graves' disease. First, there is an autoimmune, and second, there's a very unique characteristic. So what I mean about that is that yes, Graves' disease will have all the symptoms, all the typical symptoms of hyperthyroidism, plus we'll have this sign or symptom called exophthalmos. So exophthalmos is this protrusion of the eyeballs that I'm pretty sure you probably have seen people with that. Okay, this is very unique, almost pathognomonic or specific for Graves' disease. You might not see exophthalmos in any other conditions other than Graves' disease. So if you see exophthalmos in an exam, you can stop reading. The answer is hyperthyroidism, or more specific, the answer is Graves' disease. Okay, now we're going to review briefly the parathyroid gland. This is very easy because the name of the hormone is practically the same. PTH stands for parathyroid hormone. What is the main function of the parathyroid hormone? Is the opposite of calcitonin. So parathyroid hormone, the function is to increase calcium levels. Okay, calcitonin decreases calcium levels. Parathyroid hormone is produced by the parathyroid gland. Calcitonin is produced by the thyroid gland. And the important thing here to recognize is that we are looking at the levels of calcium in blood. So everything is based on what's happening, what are the calcium levels in blood. Once again, you can see here what are the major reasons why calcium levels are important. And just to give you an example of when we say nerve impulses, we mentioned in the previous videos and the previous class that if this is a neuron, and this is the axon terminal, all these vesicles at the end contains the neurotransmitters, right? So we say that neurotransmitters, they're released into the synaptic cleft. But interesting here is that what triggers or what stimulates the release of these vesicles with the neurotransmitters outside is calcium influx. So what that means is when the action potential reaches this part of the neuron, there are calcium channels, voltage cancel channels that open, and calcium can enter the cell. And that calcium is the one that stimulates the vesicles to migrate and release the neurotransmitters. So if your calcium levels are low, the neuron will not be able to release the neurotransmitter, and the nerve impulse will be impaired. Okay, so as you're gonna see, that uh, what happens when you have too few or too much calcium levels, right? And also blood clotting. All right, what are the target organs of the parathyroid hormone, right? The one that for sure you need to know is the bone, because that is the place where if we need calcium, that's the place where we're going to ask for calcium. Just remember that if we have in our blood too much calcium, the place where we're going to ideally to put the calcium, to store the calcium, is going to be in the bone, and vice versa, because calcium is stored in the bone. Whenever we need calcium, because we're lacking calcium in the blood, we're going to ask calcium in the bone. So PTH and calcitonin makes sense that the target organ in this case will be the bone, specifically the compact bone, right? Because if you remember from previous classes, we have compact bone and we have a spongy bone. But the compact bone is the most rigid, solid, and is the bone that has the bone matrix, is the one that contains most of the calcium. That's what makes the bone hard and dense and rigid, solid. Now, there are other places like the kidney and the intestine in which the parathyroid hormone indirectly targets them. Like in the case of the kidney, and this will be related with something you know from previous classes, vitamin D. So vitamin D is linked or associated with calcium. Okay, if you remember from chapter 5, I believe is yes, for AMP1, we talk about integumentary system, skin, and we learned that through the sun, through the ultraviolet light in the sun, that's the way how we synthesize vitamin D. Now that vitamin D is not active yet, or the chemical structure is incomplete, if you will. So it needs some modification. This vitamin D that comes from the skin will need to go first to the liver, and the liver will have some modifications, and then that vitamin D will go to the kidney. And then in the kidney, in the presence of parathyroid hormone, the kidney will be stimulated to create or to generate the active version of vitamin D. Okay, the active version of vitamin D is calcitriol. Okay, so calcitriol, or if you want to read this one, 1,5-hydroxyvitamin D, dehydroxyvitamin D is the long name. Calcitriol, calcitriol is the active version, is the same thing. Okay, with that calcitriol, that is the hormone that we need in the kidney to be able to reabsorb the calcium that is in the urine. Okay, so that way we don't waste calcium in the urine. But without this vitamin D, the kidney will not be able to reabsorb this calcium, and this calcium will be lost through the urine. So we need active vitamin D. PTH tells your kidney convert vitamin D. That way this calcium is not wasted in the urine, and it can be put back into the blood, increasing your calcium levels as well, which we know that is the main function of PTH. And the testing is the same thing. Without vitamin D, you can see it here, calcitriol. Vitamin D is crucial in the intestinal cells to be able to absorb the calcium that you're having through the diet, through the food. That means that you can eat tons and tons of calcium in your diet. If you're lacking of vitamin D, you're not going to be able to absorb them. So most of the time, you can imagine, lack or deficiency, vitamin D deficiency, is linked to low calcium levels. And who is the people normally has problems with vitamin D? Those people that don't get sun exposure, right? Or people that has dark skin color, because melanin, remember, melanin is a chemical that protects against the UV light, but at the same time it protects that the skin sometimes has trouble absorbing the UV light that is required to synthesize vitamin D. So let's talk about the effects of PTH in the bone in more detail now. Okay, so for that we need to remember anatomy, one, about the bone, and the two most important cells for this are going to be the osteoblast and the osteoclast. In the past, I told you the one that start with B, osteoblast. Think about them as B for building, right? Those are the ones that build bone, they create bone matrix. And the ones that has the C, class, think about that crushing or cutting, right? What they're going to cut? Bone, okay? So osteoclasts, they break down bone matrix releasing calcium. Now, this you will see that is a cycle, right? It's a cycle between the blood and the bone. And again, just if you just use like common sense, you can imagine that if in your blood, because that's what matters, the calcium levels in your blood is what matters. So if your calcium level is low, you're going to ask the bone for calcium. If your calcium level is high, you're going to put that calcium into the bone. Okay, there are disorders where we cannot put the calcium in the bone, and your blood needs to, or your body needs to put it somewhere else, right? So you will see there are conditions when we have too much calcium in our blood and our bones cannot store that calcium. We're going to start having calcium accumulation in other organs, and that will be bad. Anyway, so PTH. So what we need to think about here is that these hormones, or this hormone PTH specifically, will target these cells in the bone. Okay, so what do you think, just by logic, that do you think that, and then PTH can do two things to these cells. It can restrict the cells or inhibit the cells. In other words, telling the cells stop doing your job. And or option number two, that PTH can stimulate the cells. In other words, can tell the cells, hey, do what you're supposed to be doing more, right? So when we have and first let's just think, what triggers the release of PTH by the parathyroid gland? What is the stimulus, right? So the stimulus is low calcium levels. That is the problem, right? Low calcium level of blood, low calcium levels in blood. Okay, that low calcium level stimulates the parathyroid gland. The parathyroid gland produces PTH. PTH is released into the bloodstream, right, and then travels through the bloodstream and reach the bones. So, because the problem is low calcium, the solution is going to be finding a way to increase your calcium levels, correct? To bring the calcium levels back to the normal range. So the main place where you're going to ask for calcium is the bone. So that means that PTH, if we know that the osteoblasts, they build bone, how do they build bone? Well, they take calcium from your blood to put it into the bone. So by doing that, you can imagine that if an osteoblast is super active, the osteoblast is taking calcium from your blood and putting it into the bone. That means that your calcium levels in your blood will go down if these guys are taking it, right? So you don't want that because we have problems with low calcium. So PTH will inhibit the osteoblast. On the other hand, PTH will stimulate, right, the cells that break down bone. Why? Because again, you can imagine that those cells, when they destroy bone matrix, calcium is released, and this calcium then can be moved into the blood, and that will increase the calcium levels into your blood. Okay. Also, you can imagine that if you have, we're gonna review in just in a minute, that when you have hyperparathyroidism, meaning that you have an excessive amount of PTH that for some reason is not being controlled by a negative feedback loop, in other words, you're producing more than what your body actually needs, that means that your osteoblasts are going to be actively stimulated over and over and over again. Somebody with hyperparathyroidism, what will be the symptoms? Well, you can imagine high calcium in blood. And what's going to happen with the bones? Do you think the bones, what's going to happen with the calcium there, right? The calcium in your bones will be reduced. And when you reduce the calcium levels in your bone becomes weaker and thinner, and the bone density is reduced. So then we have problems with fragile bones that could cause fractures. We're going to talk about that in just a minute, but I like to mention that here. Calcitonin works in the exact same way that parathyroid hormone in terms of stimulating and inhibiting cells. It's just that it does in the opposite way. So calcitonin inhibits. So calcitonin is released when your calcium levels are too high, right? So if your calcium levels are too high, the solution to fix that is to find a way to bring your calcium levels back to the normal, bring that low. So thyroid hormone, right? When your calcium goes up, thyroid gland is stimulated, the parafollicular cells release calcitonin, and calcitonin goes to the bone and inhibit the osteoclast because you don't want calcium in your blood, and stimulates the guys who take calcium from the blood to put it into the bone. So it will stimulate the osteoblast. That's the way how you move calcium from the blood into the bones, and that will reduce the calcium levels in blood. All right. Disorders associated with an increase of parathyroid hormones. So hyperparathyroidism, right? We know that that means that here, for some reason, you have an excessive amount, a pathological amount of parathyroid hormone. Now, here's what I was telling you from the beginning. If you comprehend, if you understand the content, many of the symptoms, many of the way how many of these concepts you will not need to memorize them, or at least memorization will become easier if you can put your knowledge and comprehension first. So remember that if you have PTH, if you have too much, that means that the PTH is activating your osteoclast, and it's activating your osteoclast a lot. So what do you think is going to happen with the calcium, right? In the two important places. What's going to happen with the calcium in your blood? And what's going to happen with the calcium in your bone? Okay? So in your blood, if you have hyperparathyroidism, your calcium levels are going to be high, very high, because you're adding calcium into the blood a lot. So you can see that one of the things is your calcium levels in blood will be very, very high. What else? What's going to happen with the calcium in your bone? Well, it's going to be low. So that means that the less calcium you have in your bones, remember, the bone become more thinner, fragile, and that decreases basically the bone density, making the bone very weak and predisposing to spontaneous fractures or deformities, all because of the lack of calcium. Now, naturally, the bone is the place where you store calcium. So, but because you have the PTH that is stimulating this osteoclast and is inhibiting the osteoblast, your body needs to find a way where to put this excessive calcium that is in the blood. And that's another symptom you can see is calcium deposition in organs and tissues. So abnormal calcium. Which place do you think is one of them that might cause a lot of pain during urination? Okay, the kidneys. So, and what's going to happen with the kidneys, you might say? Well, have you ever heard about kidney stones? So, kidney stones can be composed by calcium. So, most of the time, if you have hypercalcemia, a lot of calcium in your blood, because hyperparathyroidism, you might have, or the patient might develop kidney stones. And sometimes those are the symptoms the patient will have. Maybe the patient will have, sometimes the patient might be completely asymptomatic, and you might find, or the patient will realize that they have hyperparathyroidism because they do a blood test, like just a routine blood test, and they found the calcium was high. Then when the calcium is high, you say, maybe let's check parathyroid level. And if the parathyroid level is high, it has hyperthyroidism. Other symptoms of hyperthyroidism might be kidney stones. Okay, so kidney stones, you look at the stones in the microscope, see what type of stone is. And if it's calcium oxalacetate, you know that is calcium, so that might be related with hypercalcemia, and you can start that way. Now, when it's extremely severe and untreated, that's when you start seeing spontaneous bone fractures and deformities. Also, the calcium levels in the blood. One of the things I told you before, calcium is extremely important. So when you have too much calcium, the membrane become less excitable, so it's or less permeable. So it's harder to stimulate through a nerve conduction cell membranes. Okay, so the nervous system is reducing hypercalcemia. We will see that in hypocalcemia, the cell membrane becomes way more sensitive, and the symptoms are going to be related with that. The opposite condition, when you have a deficiency or a hyposecretion of parathyroid hormone, you might develop hypothyroidism. Hypothyroidism is characterized by low calcium levels. Where? In blood, right? That is where it's important. And we said a few seconds ago that when you have high calcium levels in blood, high calcium levels decreases the membrane permeability and sensitivity, so it's harder to, through an electrical impulse to stimulate a tissue that the cell membrane is the threshold or the stimulation is lower. So in this case, when your calcium levels are low, that increases the cell membrane permeability, and that causes that a minimal action potential will stimulate the organ. Could be a muscle, or could be, and when they are muscle, that means a skeletal muscle. It could be the heart, right? So low calcium levels can cause arrhythmias, for example, and also it can cause all these symptoms, right, which are muscle symptoms, right? Twitching, spasms, all these are symptoms of uh, tetany, which is this involuntary muscle contractions. Even can affect the nervous system and cause seizures or convulsions. The cause of hypothyroidism could be hypoparathyroidism, primary hyperparathyroidism, meaning that for some reason your glands are not working anymore and do not produce PTH. Or the most common type is after a thyroid problem. People thyroidectomy, which means total remove of the thyroid gland during surgery, sometimes because they have a cancer, because they have hyperthyroidism, and they have to remove the thyroid gland so the person is not hyperthyroidism. Sometimes when they remove the thyroid gland, they also will remove the parathyroid glands because, again, they're very tiny, they're attached to the thyroid gland, and that will lead to hypoparathyroidism after a surgery or an injury that involves the thyroid gland. That is based on the anatomy. Uh, Other causes, again, that's the most important information for your exam. But as I mentioned before, if you have very severe vitamin D deficiency, you might also develop low calcium with the thyroid levels, the parathyroid levels, normal, right, or high in this case. But when we talk about the problem itself is the parathyroid glands, this is primary hypoparathyroidism. Okay, let's move on, and now let's cover the glands the adrenal glands, and let's review those glands that we have in the abdomen. Okay, if you've been following me in the way that I recommend you to know these glands based on the region, the number you need to remember is two. I don't know if you notice that, right? In the head, two glands, pineal, pituitary gland. In the neck, two glands, thyroid gland and parathyroid glands. In the chest, two, and those are not uh, primarily organs, but well, one of them is like the thymus, and the heart is a secondary organ, but two organs are related with hormones, right? We're going to see those later. And then in the abdomen, we can think about this: pancreas, adrenal gland, those are two, and those are primary organs. Also in the abdomen, we're going to find two organs, kidney and small intestine, that are secondary, but again, the two repeats. And then when we look about the pelvis in the female, we have the ovaries and the testes. Those are two. So everything is two, right? And if you just know that, very simple, uh, based on the regions, that's a big help in order to, for you to identify glands in an exam, and be able to say, just based on the region, what gland most likely is the one that you're looking at. Okay, so let's learn some general and basic concepts about the adrenal gland, right? First is the location. We know that those are those glands that have like a kind of like triangular shaped glands are on top of the kidneys. Everybody is able to identify the kidneys. They're very easy to identify. They look like they're bean-like shapes. They're way deep in the abdomen. So really, in order for you to be able to see them, it means you have to take a lot of things. You have to take the liver out, you have to take the stomach, and then the intestine, small and large intestine, in order to be able to see them because they're very deep. Now, for AMP2, again, you need to know now that the adrenal glands has two regions. Okay, so, and what I'm saying is in your lab or in your lecture, the answer is not going to be adrenal gland. The answer will be either adrenal medulla or adrenal cortex. So why is important to be able to recognize those regions? Because the hormones. So the adrenal glands, I told you that form basically or synthesize four hormones. One of them is produced here in the medulla, which is epinephrine or epinephrine, and the other ones are produced in the cortex. So three hormones are produced in the cortex, and the cortex itself is subdivided in three zones. Three hormones, three zones. What do you need to know here? G, F, R. So G for glomerulosa, zona glomerulosa, zona F, fasciculata, and R, reticularis. Okay, GFR. I remember this just because, and normally GFR stands for something in the kidneys, glomerular filtration rate. That's how you measure if the kidneys are working properly. But it helps me to remember GFR for glomerulosa, fasciculata, and reticularis, and then the hormones they produce. We're going to see it now. Okay, this is very quick, something that I already mentioned in the previous slide about the zones of the cortex and the medulla. This is a real picture of the adrenal gland. Has been stained. Of course, you can see the different zones. You can see the colors. It's not worth it for you to memorize that. You're not going to be asked about that, but at least you can see why we have this division. What is important is to know the hormones, right? And I'll recommend you to memorize first adrenal medulla because it's just one. The hormones are the catecholamines, epinephrine or epinephrine. The way how you stimulate this specific part of the adrenal gland is using a nerve. And this nerve is a nerve that belongs to the sympathetic nervous system. And every time that you need these hormones, that's how your body stimulates the adrenal gland to release them in the fight or flight responses, right? Epinephrine, as you probably know, increases blood pressure, is the one of the hormones that when your life is in danger is going to be released, right? Epinephrine or adrenaline is the same thing. And also in the clinical relevance about epinephrine is that people has epinephrine or EpiPens, right? Those people, whenever a patient has an EpiPen, that means that they are allergic to something and they're severely allergic to something. That EpiPen is used if they develop a severe allergic reaction, what we call anaphylactic shock. Okay, EpiPen is what is going to save your life if you have anaphylactic shock. Every time you see that or you hear the word shock, that means that your blood pressure is too low and your body is unable to bring your blood pressure high. And with low blood pressure, no perfusion to the organs and death, right? So EpiPen is this injection that you're going to use when somebody has severe anaphylactic shock to bring the blood pressure up. So that's the one that you need to know first. And the other three, GFR, glomerulosa fasciculata, and reticularis from the glomerulosa, mineralocorticoids, but the most important one, the hormone that you need to remember is aldosterone, related with blood pressure, and sodium. So we're going to talk about that in a minute. From the fasciculata, the glucocorticoids, the most important glucocorticoid is cortisol. And the same thing, we're going to learn those functions in just a minute now that we're going to cover one by one in zona reticularis, androgens, those are the sex hormones. We're going to talk about that also about them briefly in just a minute. Okay, from the adrenal cortex, let's review the first one, which is aldosterone. Okay, the main function of aldosterone, as you know, is here you can say is important in the regulation of concentration of sodium, potassium. That's what the hormone is doing, but what is the effect, honestly? What is the thing that is important? So really, aldosterone is something that is a hormone that first is produced by the adrenal gland. Okay, so adrenal gland produce aldosterone. Aldosterone will target the kidney. So the target organ is the kidney. And aldosterone, you will see that what it's going to do is, because with the kidney, remember, is the organ that makes urine, that produces urine, right? So basically, it prevents sodium to be wasted through the urine. So in other words, it will reabsorb sodium. And the way how these work is that sodium will go out of the kidney, so it's not wasted in the urine, in exchange with potassium. So potassium will move in the opposite direction. Potassium, if this is the blood, right, and here we go to the urine. So basically, aldosterone will stimulate the kidney to reabsorb sodium in exchange with potassium. So that means potassium will be wasted through the urine and sodium will be recuperated with the urine. And also, every time you move sodium, there's the easy way to remember this: sodium has like an osmotic force that pulls water. So for to simplify, think about every time you move sodium, you move water. And what happens when you add water into your blood, right? That's the main reason why we need aldosterone, is to increase blood pressure. So you will see that the situations when aldosterone is released is when your blood pressure is low and your body is trying to fix that using the endocrine system, bringing the blood pressure up. It's going to be an illustration of what I just said. Now, bear with me here because it gets complex. We're going to review this in more detail, maybe in the urinary system, but I think it's worth it for you to know at this point so you have an idea already. This gland is the adrenal gland, and this is the gland that will produce aldosterone, and aldosterone will stimulate the kidney, right? Now, the real story here, the really detail how this, who is, okay, we know the adrenal gland is stimulated to produce aldosterone, but who stimulates the adrenal gland? Is not the ACTH, right? Adrenocorticotropic hormone. Because if you use ACTH, basically you're asking the adrenal gland to make cortisol. So it's not that. It's not a nerve, because if you use a nerve, what you stimulate is the medulla or catecholamines. So it's a substance, is another hormone called angiotensin 2. Okay? So angiotensin 2 is the hormone that stimulates the adrenal gland to release aldosterone. But to make the things more complex, here's what happens. And again, let's look at the function of aldosterone first. Aldosterone, to keep it simple, is the hormone that will increase your blood volume and will increase your blood pressure. That is the main function. How is that aldosterone increase blood volume, blood pressure? That has to do with sodium and it has to do with water. Okay, we're going to see that. We're going to explain that in just a minute, but just keep that in mind, because what triggers the release of aldosterone, if you know the function is high blood pressure and high volume, is the opposite. So when your body, if you're severely dehydrated, or if the doesn't have here blood volume, right? Like when you're dehydrated, that is what stimulates your body, okay, to, and specifically your kidney, to release a hormone called renin. So after we cover adrenal gland, pancreas, blah, 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 we're going to see the kidney as a secondary function. I'm anticipating that. Renin is a hormone produced by the kidney every time that your blood pressure drops or your volume is low. Or if you have, for example, I said that the kidney has an artery and has a vein, right? The artery is the way how blood enters the kidney. If you have stenosis, or if the artery is partially occluded because you have fat or something that is occluding the blood flow, the kidney will think, hey, the blood pressure is low because we're not receiving enough blood, right? And that will trigger the release of renin. So renin, again, is this hormone produced by the kidneys when your blood pressure goes low or when you are dehydrated. Renin, or when your osmolarity is too high in your blood. So renin then will activate, and I don't think that is, I'm going to mention it, but again, this is something we're going to look in more detail in future classes. Renin essentially is the hormone that transforms angiotensinogen, right, into angiotensin 1. Angiotensin 1 is going to, you know, travel through the bloodstream and will reach the lungs. And in the lungs, we have an enzyme called angiotensin uh, converting enzyme, right, or ACE. This is, if that ring a bell, there are medications for blood pressure that are called ACE inhibitors, medications that target this enzyme in the lungs that prevents the transformation of angiotensin 1 into angiotensin 2. So ACE inhibitors, which are medications for blood pressure, are the ones that affect that. So with the goal of to preventing, production of angiotensin 2, which eventually triggers the release of aldosterone. And aldosterone, we know, increases blood pressure, blood volume. If you're treating somebody because they have high blood pressure, you use an ACE inhibitor. So no angiotensin is produced, no aldosterone is produced, and that way we can bring the blood pressure down. But again, that is pharmacology. It's something you're going to learn in the future. I mentioned this here so you have the whole picture. But what you need to know for your exams is that the same kidney, the one that is detecting blood pressure is low and everything. This is the one that is going to stimulate the adrenal gland to ask for the hormone that will stimulate the kidney itself. So that's what I'm trying to tell you here with all of this, that it's kind of, I don't know, it's kind of funny, right? That make that funny loop there, that the kidney stimulates, releases renin to stimulate the adrenal gland just for the adrenal gland to produce a hormone that will back and stimulate the kidney to do what I'm going to show you now. So once aldosterone enters the kidney, so the kidney, what it's going to do, again, normally the kidney, if substances move this way, what we have here is urine, right? So, and everything that leaves the kidney through the ureter is going to go to the bladder, and then we cannot recuperate that. That's going to be lost. So if you have too much water or electrolytes, etc. Anyway, so aldosterone, what it stimulates is the reabsorption. So I'm going to put here, because this is the key word here, increases, I'm going to make this arrow up, okay, increases reabsorption of sodium and consequently or secondarily or indirectly reabsorption of water, because water follows sodium. So if you reabsorb more sodium, that means that that sodium is going back to your blood. And also with the sodium, water is going back to your blood. So when you add water to your blood, when you keep the water into your blood, that increases the blood volume. And if you increase the blood volume, you increase the blood pressure. What's going to happen with the urine? Well, you're taking water from the urine, right? Because you're reabsorbing it together with the sodium. So you're going to have less urine, okay? So the urine, in terms of volume, will be less or will be more concentrated. You will have less urine, less sodium, and you will have more potassium, because I told you before, the way how the kidney moves sodium is by exchanging with potassium. But potassium is something that is more detailed. Just take care, or just remember sodium at this point. Okay, this summarizes what I just explained. So to keep it simple and straight for you, this is what you need to know about aldosterone. Okay, this is primarily the main thing you need to know, and we're going to learn at the end. There are three hormones, and I'm going to tell you right away. So when I mentioned before, hopefully you will remember it. There are three hormones that are important controlling your blood pressure. Okay, so two of them are the purpose is to increase the blood pressure. This is aldosterone and ADH. The way how they increase blood pressure is by increasing the amount of water. The only thing is that ADH will do that directly, meaning directly will stimulate the kidney to reabsorb water, right? Uh, while aldosterone do that, but in a way that is indirectly. So really aldosterone stimulates the reabsorption of sodium, and with sodium, water. Now there's another hormone that is related with low blood pressure. So when this hormone is released, the purpose is to bring your blood pressure down. This is a hormone called ANP, and ANP we have not reviewed that yet. But those are the three hormones that are going to be, or they're important for your exam to remember, that affect your blood pressure. Aldosterone, think about adrenal gland. ADH, think about hypothalamus. And pituitary gland, posterior, right, of course. And AMP, think about the heart. Right, so heart, AMP. And then those, all of them, they will target, so aldosterone, ADH, AMP, they will target your kidney. That's the target organ. And the kidney, by manipulating the kidney to keep or to get rid of water, that's going to affect your blood pressure. All right. Okay, now let's talk about the second hormone produced by the adrenal cortex from the zona fasciculata, cortisol. Before we do that, I want you to look at these two pictures I have here for you. Are you familiar? Have you ever heard about somebody taking prednisone or somebody using hydrocortisone cream? When do we use this stuff, like this cream? Just look, skin rashes or irritation, right? Redness, inflammation. If a bug bites you and your skin is rough and inflamed, you might use an steroid. These are what we call steroids. Prednisone, the same thing, right? And people who takes prednisone, people with, we have problems with asthma, for example, or if you have a severe inflammation or autoimmune disorder, that is okay. Examples of these may be like a rheumatoid arthritis, or people who has chronic inflammatory disorders. They're gonna take steroids. Steroids like prednisone, hydrocortisone, those are things that are synthetic. So those are medication drugs. Our body produces, naturally, the natural steroid that our body produces is called cortisol. Right? So that is the important part here, cortisol. And it's important because when we review the disorders, we're going to see that there are two conditions in which we have too much cortisol and another one where you have a few or deficiency of cortisol that you need to know for your exams. So cortisol is a big thing. What are the functions of this natural steroid that our body produces, right? So the first one, as you can see here, cortisol is important to increase your blood sugar levels, specifically in two important situations. In long-term stress, like when you're severely ill or when you're, fighting an infection, and the other one in fasting states. Like, for example, if you every time you eat when you go to sleep. In fact, if somebody wants to check your cortisol levels, they will check your cortisol levels early in the morning because that's the time when the cortisol is higher. Because again, when you're not eating, when you're fasting, your sugar is not coming from your digestive system. The glucose is not coming from the stomach, intestines, right? The glucose will come from your reserves, so from either your liver or your fat tissue if you use different hormones. But the point here is that cortisol is the hormone that maintains normal blood sugar levels or glucose levels in a fasting state. Also, the other functions of cortisol that are important is that cortisol, this is natural steroid, can affect your immune responses, okay, your immune system. So how the immune system is affected by cortisol? Well, this depends on the amount. Depends, and I think to explain this better, uh, it's better if we use medications because that's the clinical concept that is important when we can see that in the practice. So I said before, prednisone, you use that in patients who have asthma, right? Asthma, what they have is an inflammation or there's a overreaction in the airway to something, to dust, to some sort of allergy, and that is causing hyperreaction. So it's causing that the airway gets inflamed, the airway produces more mucus, blah, blah, blah. So if you give somebody steroids in certain amount, right, the effect in the immune system is that the steroids reduce inflammation, so inhibit inflammatory responses. Okay, that is the typical time when you use steroids is to reduce inflammation. Now, if you use an steroid in large quantities, okay, so not just, let's say, not just two to say increase, but you're using steroids in a large amount, high doses of steroids are immunosuppressive. What does immunosuppression mean? What does that mean? It means that impairs your immune system. And you might ask yourself, why do we want to do that? Or when this is something that is medically beneficial, right? Inhibit your immune system will not make you sick. Well, transplants, organ transplants is one of the times when you're gonna see somebody taking steroids in large quantities to immunosuppress the immune system to prevent that your immune system reject the new organ, right? So that is the place in organ transplants. If you gave them high doses of steroids, is immunosuppressive. If you give just steroids in normal quantities, is anti-inflammatory. I'm not going to repeat a lot of this because we mentioned that before. Just keep in mind, if you want to stimulate the adrenal gland to produce cortisol, you need to use ACTH. ACTH is a hormone produced by the pituitary gland. But if you want to stimulate the pituitary gland to produce ACTH, you need to stimulate the hypothalamus, okay? Because the hypothalamus produces this hormone, which again is not worth it to learn at this point for you. But that's the hormone that the hypothalamus releases to stimulate the pituitary gland. So who stimulates the hypothalamus then, right? Well, that's the cycle. This is the negative feedback loop, okay? So ACTH, adrenal gland, cortisol. So the main stimulus is this. If the cortisol level, so if your corticoid, or let's just keep it simple, cortisol level is low, okay, we need to fix it. So that low cortisol level is the stimulus that triggers the release of CRH by the hypothalamus to stimulate the pituitary gland for the release of ACTH, which ACTH will stimulate the adrenal gland to produce cortisol to try to bring the cortisol levels back up, okay? And vice versa. If your cortisol levels are too high, right, it's too much, that is the stimulus that will, again, target the hypothalamus, and the hypothalamus will stop producing these hormones, so your adrenal gland will not produce cortisol. The last one, there's not a lot to say here other than what we have in the PowerPoint here, is the zona reticularis is associated with the production of sex hormones called androgens. Androgens are especially important in females that have association with an increase of libido or sex drives, and they turn more important. The androgens become more important after menopause. So in postmenopause in females, when the ovaries stop producing um, estrogen, then the main source of estrogen in a female becomes from the um, adrenal gland, even though the amount most of the time is not enough. The adrenal medulla is the last part, is the central part of the adrenal gland, and this is stimulated. The way how you stimulate the adrenal gland is through the sympathetic nervous system. So there's a nerve that directly comes out of the spinal cord and goes all the way to the adrenal gland and releases a neurotransmitter there, that when you have a response, like a situation that, for example, your life is in danger, a life-threatening condition, that nerve of the sympathetic nervous system will release norepinephrine into the adrenal medulla, and that is going to stimulate the adrenal medulla to produce all the catecholamines, so even more epinephrine and norepinephrine. And then when you have all these hormones in your blood, that all of them together, that's what causes the fight or flight response, which is characterized by all these: increase in heart rate, sweat, bronchodilation, increase in blood pressure, vasodilation, mydriasis. For your exams, just make sure you know fight or flight responses has to do with catecholamines. Catecholamines are secreted by the adrenal medulla. All right, let's review the disorders of the adrenal glands. We're going to focus on cortisol. So I told you before, cortisol, we have two possibilities here. The levels are too high or too much, or we have a few or deficiency. Okay, so if we have too much cortisol, right, an excessive amount of cortisol, we have Cushing's. And then Cushing's, in reality, the problem here, or in reality, what this is called is Cushing's syndrome. Now, Cushing's syndrome is anything that is increasing your cortisol level. Now, there's a subtype, or there's a specific thing called Cushing's disease, which is a problem, and this is the one that you primarily need to know for your exams. Unfortunately, this is not the most common. The most common is Cushing's syndrome that you're gonna see in the practice. Syndrome. Cushing's disease is, the problem here is the pituitary gland. So Cushing's basically means you're gonna have too much cortisol. And cortisol, we know that is produced by the adrenal gland, but the adrenal gland is not the problem. The problem is the pituitary gland. There is a tumor in the pituitary gland that is secreting ACTH in large amount. So there's too much ACTH, and ACTH is constantly stimulating your adrenal glands, and your adrenal glands constantly will produce cortisol. This is what we call Cushing's disease. So Cushing's disease is a specific pituitary gland tumor that produces ACTH, and secondarily, your adrenal glands will produce cortisol. Now, who controls ACTH production and release? Is the hypothalamus, right? The hypo, hypo T, okay, hypothalamus. Hypothalamus, when you have that tumor, most likely the levels of the hormone that the hypothalamus produce is low, because the hypothalamus really do not want that large amount of ACT is produced. But however, because it's a tumor, the tumor doesn't listen. The tumor doesn't care. The tumor keeps producing in a in a way that your body cannot control an excessive amount of ACTH. Now, that is the ones you need to know for the exams. The characteristics of Cushing's disease, we can see that in this picture. So if you remember these, or you have seen maybe people that has this, or that looks like that, right? Those patient has a Cushingoid's characteristics or Cushing symptoms, right? The first one is they're overweight. And why do you think they their weight gain? Right? The main reason is, if you remember, cortisol increases your glucose levels. So cortisol increases your glucose levels. In cortisol, when you have an excessive amount of sugar, your body do not use all that sugar, will transform that sugar in fat. And then that fat will be accumulated in the tissue and under the skin and your subcutaneous tissue. Also, you can imagine that somebody with high cortisol, high glucose levels, and for a long period of time, they will develop diabetes mellitus. So that is what explains the weight gain is cortisol, high glucose, the excessive amount of glucose leads to diabetes, but also the excessive amount of glucose in order to be stored in your body will be transformed in fat, and that is the one that accumulates. That also explains this moon-shaped face. Basically, what that means is all the fat that will accumulate around the cheeks, and that will make this face like a round. Also, this buzzword, if you see this in an exam, buffalo hump, is this fat pad tissue in the back. If you see that, that is a very characteristic of Cushing's syndrome or somebody with Cushing's disease. You can see, and you could read other ones like hair loss. Also, people with Cushing's will have all these stretch marks. The skin will suffer. They will have poor wood healing problems there, and other problems associated with what we call metabolic syndrome, diabetes, and that. So what's going to happen with somebody, and again, I told you this is what you need to know for your exams, but this is not the most common. The most common way how you have high cortisol is when you take medications. When you take steroids, prolonged steroids is what really causes Cushing's syndrome, is the most important cause. And who takes steroids in long, chronically? Patients who have autoimmune disorders like rheumatoid arthritis or some sort of inflammatory disorder that require steroids for long periods of time. So what do you think is how it's going to look, the ACTH? How you can differentiate between somebody who is having Cushing's because they're taking medications versus somebody who has Cushing's because they have a tumor in the pituitary gland. The key here is the ACTH, right? And somebody who is taking steroids, right, exogenous or orally, the ACTH will be low because the pituitary gland is trying to, the hypothalamus is detecting too much steroids, so it's inhibiting the pituitary gland, and the pituitary gland is inhibiting your adrenal gland. But you still have high levels of cortisol because you're taking them. You're taking them in pills. So the ACTH will be low in somebody who is taking steroids. They have Cushing's syndrome. In somebody who has Cushing's disease, the ACTH will be high because here the problem is the pituitary gland is producing that. Okay, the next disorder we're going to see is Addison's disease. Addison's disease is the opposite in some way or another than Cushing's disease. Cushing's disease, we said, is too much cortisol. In Addison's disease, we're going to see low cortisol low cortisol levels. But in reality, Addison's is a type of adrenal insufficiency. What does that mean? That the adrenal gland is not able to produce the hormones that it normally produces, right? So Addison's disease specifically is, I believe, is caused by an autoimmune disorder that destroyed the adrenal gland, and the adrenal gland becomes insufficient, insufficient. Therefore, you will have low cortisol. But also, you can see here, what else is produced in the adrenal gland? Sodium. Aldosterone. And aldosterone is the hormone that regulates the amount of sodium. It's the one that prevents from your kidney to lose sodium through the urine, right? So without aldosterone, you will lose sodium in your urine. Therefore, your blood levels of sodium will go down. Also, remember cortisol. It regulates your glucose. Blood pressure also will be low. These are all the symptoms related with Addison's disease. What I want to tell you here is that in Addison's disease, your ACTH will be high. Okay? So the adrenocorticotropic hormone will be high. But why? Well, remember that your hypothalamus is detecting that the levels of cortisol are low. So the hypothalamus says, hey, the cortisol is low. We need to increase the cortisol level. So the hypothalamus is trying to stimulate, not trying, is stimulating the pituitary gland, and the pituitary gland is producing, I'll put PG for pituitary gland, is producing this large amount of ACTH in an attempt to stimulate the adrenal glands to produce cortisol. However, remember, the adrenal glands are not functioning. So therefore, this is a vicious cycle in which the hypothalamus starts producing more and more and more hormone to try to stimulate the it's kind of funny because the hypothalamus is telling the pituitary gland, hey, produce ACTH. We don't have cortisol, produce ACTH. And then the pituitary gland is telling the adrenal gland, hey, produce cortisol. And so the amount of ACTH is extremely high, but there's not cortisol because the adrenal gland is not working. The point of this that I want to make is this hormone that the hypothalamus, when it's producing large amount, okay, ACTH increases the amount of ACTH, right? But also it stimulates the production of something called MSH, okay? Which MSH stands for melanocyte stimulating hormone. Now, this is just an extra that I'm explaining, so you might know, and I'll put here melanocyte stimulating hormone. I just mentioning this because this matches one of the symptoms of somebody with Addison's disease. So large amount of hormones that come from the hypothalamus it stimulates one in the pituitary gland to produce ACTH, but also it stimulates the skin, right? It stimulates the production in the skin of melanocyte. So melanocyte is stimulation hormone. Remember what the melanocyte in the skin does, produce melanin. And if you remember what is melanin, is the pigmentation of the skin. So when you have a lot of melanin, your skin starts changing in color. And this is what we call skin pigmentation, which it causes like a bronze pigmentation. I have a picture of the president because the president F. Kennedy has Addison's disease, and that's where his skin and his pigmentation always looks like that. It's also like kind of browns, like he was always in the sun, right? But it was really coming from the Addison's disease. Once again, you see why this skin pigmentation happens, right? The symptoms of Addison's: weakness, craving for salty food, weight loss and all that is related with the lack of all the hormones, um, the adrenal hormones. But for your exams, make sure you know that cortisol will be low. Let's review the endocrine pancreas, and we're going to see why this is called endocrine pancreas and not just pancreas. So the pancreas sometimes is referred or is an organ that belongs to two systems, endocrine system and digestive system. Sometimes you're going to heard or read exocrine pancreas and endocrine pancreas. But this is something that applies to all the glands. We have exocrine glands and endocrine glands. I told you before, an exocrine gland is a gland that whatever they produce, they release the content outside of a blood vessel. Like your sweat glands, they're exocrine glands because the sweat is delivered into in the surface of the skin. If the sweat gland will deliver the sweat in your bloodstream, well, the sweat gland will be an endocrine gland, but that's not the case. Or sebaceous gland, the same thing in the skin. Those that produce oil, they release that into something different than a blood vessel. So in this case, the pancreas has a portion that produces enzymes and chemicals that are going to be released into the duodenum. And that's going to be important for digestion. We're going to see that you need hormones. Hormones are going to target the pancreas in some point to produce those enzymes that are important for digestion. That is the part of the pancreas that are called exocrine, right? In the pancreas, we have a picture of the pancreas over here. I hope you can realize that in order for us to be able to see the whole pancreas, some organs has been removed. Can you guess which organ is the one that has been removed in order to see the pancreas? Okay, so the stomach. The stomach is the organ normally covers most of the pancreas, and also the large intestine, the transverse colon, goes kind of on top of it. So we have to remove those organs in order to expose and be able to see the whole pancreas. Also notice that this is the head of the pancreas, the body of the pancreas. This is what we call the tail. And the tail of the pancreas always is associated with this organ, the kidney. Not right, the spleen. The spleen, we only have one, doesn't have adrenal glands. So students, for some reason, confuse the spleen with the kidneys all the time. So the spleen is related to the tail of the pancreas. Now, the pancreas, if you cut it, there are two groups of cells, all right? This group of cells called the acinar cells, those are the ones that are related to the exocrine pancreas. Those are the ones that produce pancreatic juice. Through this duct, they deliver that into the duodenum. But the importance or the group of cells that you need to know for your exams for sure is the pancreatic islet. Okay, is the other group. Pancreatic islets or islets of Langerhans are the group of cells in the pancreas. These alpha cells, beta cells, those are the ones that are going to produce hormones that are related to the endocrine system. The two more important hormones that you need to know is glucagon and insulin. Somatostatin and pancreatic polypeptide, just read about them. For sure, you need to know insulin and glucagon. Make sure you know islets of Langerhans. Those are found in the pancreas. Islets of Langerhans are the same than the pancreatic islet. This is the place where we have alpha and beta cells, the ones that produce the hormones important for the endocrine system. Okay, so the alpha cells produce glucagon, the beta cells produce insulin. And if you know insulin is something that probably at this point many of you will know that this is related to diabetes, right? The other ones, just again, read about it. Let's take care of the glucagon and insulin functions first. Okay, now that we know that glucagon and insulin, they're antagonists because they do the opposite thing. Glucagon increases blood sugar, okay? Increases glucose in blood. So when you have hypoglycemia, meaning if your glucose levels drop, Okay, the normal glucose levels is between 70 and 100. That is the normal. Here it says 110, but you know, in reality, above 100 is like, in the practice, that is not, especially if it's fasting, that is slightly abnormal. That will be something like called, have some degree of insulin resistance there, but not at the point to be called diabetes. Um, some sort of impairment. But anyway, so 70 to 100. You don't need to know that value. What you need to know is that if your sugar goes down, okay, low, your body needs to fix that. We early, uh, or in the older video, we talk about what can kill you faster: high blood pressure, low blood pressure, or high temperature or low temperature, or in this case, low sugar and high sugar. Low sugar will kill you faster than high sugar. In fact, you know, high hyperglycemia, high sugar levels is what is diabetes, right? Diabetes is chronic. I mean, if it's extremely, again, if we go to the extremes, yeah, it will kill you, right? But hypoglycemia is way more dangerous than hyper. So hypoglycemia, your body will respond by releasing. And what when you are hypoglycemic, that's a situation in your body is stress because you have to fix it. So one of the hormones that your body will produce is glucagon. Glucagon will be released by the alpha cells in the pancreas, and glucagon targets the liver primarily. Okay, so in the liver, that's the place where we have a lot of sugar and stored in the liver, and the liver, in response to glucagon, will break down that glucose and will glycogen, and will convert that into glucose to bring the glucose levels back to the normal range. Also, which other hormone do you think in a situation with hypoglycemia will be released that also increase your sugar levels? Okay, we talk about it is cortisol. Okay, so cortisol, when you have hypoglycemia, also will be released because cortisol is also a hormone that will increase uh, your glucose levels. Insulin do the opposite, the glucagon, the opposite that cortisol. Insulin is the hormone that we need to decrease your blood glucose levels. So when your glucose levels are high, right, this is called hyperglycemia, um, your pancreas will produce insulin. The beta cells in the Langerhans and the islets of Langerhans are going to respond to hyperglycemia by releasing insulin. And insulin target primarily your muscles and your adipose tissue, but also it's important here to recognize that in a way your insulin inhibits or tells your liver, hey, do not break down glycogen, you know, to make sugar. So basically do the opposite, the glucagon, right? And but the main target there is the muscles, and the muscles and the adipose tissues are the ones that are going to uptake the sugar that comes from that is in the blood. And when you have a disorder, which is what we're going to focus with diabetes again, because it's very common, uh, you will have diabetes mellitus when your sugar cannot be controlled. So diabetes is characterized by chronic high glucose levels um, in blood. Okay. Also, you should know that glucagon we have in its clinical relevance is that exists in an injection. So, and the same thing for insulin. Okay, insulin. Many of you probably know, diabetes type 1 will use insulin, but also glucagon. And who has or who are the ones who usually get glucagon or has a glucagon pen? Well, those diabetics. Sometimes if you overshoot or overdose yourself with insulin, if you put too much insulin, that can cause hypoglycemia. And in that case, if you have a glucagon pen that can save your lives, life to go to the hospital, right? Because if you don't, and if you have severe hypoglycemia, you're going to pass out, you're going to die. So that's why people with diabetes will have a glucagon pen, and the ones that are going to have a glucagon pen are those primarily that are using insulin to control their diabetes. Okay, as I mentioned before, insulin is important because it facilitates the uptake of glucose into the body cells, which is the target tissue, muscle, and adipose tissue. In fact, without insulin, the muscles, your skeletal muscles, are not going to be able to take the sugar that is in your blood, the glucose. So what happens is that you can have tons and tons of glucose. If your tissues do not have insulin, that glucose will not be removed from your blood, and that is the genesis of diabetes mellitus. It's an excessive amount of glucose in blood that the insulin cannot fix. So there are organs, of course, that are insulin independent, so like the brain, the kidneys, or the liver in some degree also, that they don't need insulin in order to absorb glucose uh, from the blood, but the vast majority of the organs they do, they need insulin. So when we talk about diabetes mellitus, and I explained this in the other video, mellitus means honey, right, in English. Diabetes is characterized by chronic high glucose levels in blood. So when you have too much glucose in your blood, eventually you're going to see that, or let's put it this way. Normally, you shouldn't, your kidneys should not leak glucose in the urine. What that means is that when the kidney is filtrating the blood, it will reabsorb 100% of the glucose. So if somebody has a urine test and it shows glucose, and sometimes it will show just 1 plus, or sometimes it will show 2 plus, or sometimes it will show more, or just the color. Glucose in the urine is abnormal. Okay, it's always abnormal. So you shouldn't have any glucose in the urine. But in somebody with diabetes, you have too much glucose in your blood that overcomes the ability of the kidney to reabsorb all the glucose, and therefore you're going to start seeing glucose in the urine. And that is the base, or that is the origin of the word mellitus, is urine that has glucose. What are the symptoms of somebody with diabetes? The symptoms are the primary symptoms, right? At least initially. Polyuria, which means urinating more. Polyphagia, which means eating more. And polydipsia, which means drinking more. What makes you urinate more? Well, glucose is an osmotic um, chemical that pulls water. So every time you have glucose in the urine and the kidney, that sucks water in the same way how sodium sucks water, right? So just glucose is stronger. So if you have sugar in your nephrons and in your kidney, that will pull water, and you're gonna start losing water to the urine. When you start losing water to the urine, you're urinating more. That is polyuria. When you urinate more, that will dehydrate you. So that causes, for you to be thirsty, and you're going to start drinking to try to compensate that. When you start, remember that also um, when you're losing all this water, your blood is becoming more concentrated. So the osmolarity in your blood increases, not just because you're dehydrated, but also because you have a lot of sugar, which is a solute, and that will trigger, uh, the thirst, right? You will be thirsty, and you're gonna drink more water. Why polyphagia? Well, you're gonna be hungry because your cells, these guys, the skeletal muscles and the adipose tissue, your cells are hungry. You have a lot of sugar, a lot of glucose, which is the fuel, to generate ATP, but your tissues are not able to take that from the blood because the problem with insulin. So let's see what happens. There are two disorders, diabetes type 1 and diabetes mellitus type 2. Both disorders lead to high glucose levels, but it has to do with insulin. Diabetes type 1, the patients do not produce insulin because it's an autoimmune disorder, so it means the immune system, for some reason, start attacking those beta cells in the pancreas and destroys them. And remember that those are the cells that produce insulin. So, and it doesn't destroy them, all at once. It's something that is progressive. But most of the time, that happens during childhood. So diabetes type 1 usually is associated with early onset of diabetes, and they require 100% of the time insulin because they do not produce any once the immune system gets rid of all the cells. They will have zero insulin and they will be depending on insulin. If somebody is taking a medication, and it could be somebody who is young, somebody who is 10, 11 years old or whatever, and if they're taking something orally for sugar, you can say they don't have diabetes, okay? Because there's not an insulin that is oral, it's always injectable. So that is the thing. They 100% depend on insulin. What about diabetes type 2? Does the pancreas produce insulin? Yes. The pancreas produces insulin, but the problem here is the target organs is resistant. So they have insulin, but the muscle tissue and the adipose tissue are resistant to insulin. So the pancreas needs to produce more insulin in order for them to be able to stimulate the target organs, in order for them to be able to take the glucose. This resistance to insulin is not fully 100% understood why the body develops this resistance. There's some genetic component, but the vast majority of the risk has to do um, with the way how you eat and the way how you have if you have a life that is sedentary, has to do with environmental conditions more than genetics. Anyways, or the way, of course, how you eat, right? If you eat a lot of sugar, it's like smoking, okay? When somebody smokes, they develop tolerance. So what one cigarette will make an effect initially. Then as they smoke more and more, they need more cigarettes in order for them to feel satisfied. So the same thing here, the same concept in terms of insulin. When you have sugar in your blood, like glucose it spikes. If you eat too much carbohydrate, your pancreas will produce insulin, but eventually your body will develop tolerance to the insulin in a point that more insulin is required to stimulate your organs. So diabetes can be controlled with medications that are oral medications. However, you will see that some patients, in some point, the pancreas basically gives up. The pancreas is like, okay, I give up. I cannot produce more insulin. And then the pancreas becomes insufficient. At that point, then patients with diabetes type 2, they might have uh, insulin as a treatment as well. So insulin, what I'm trying to say here is that insulin is not just for diabetes type 1. You can see insulin in diabetes type 2, but diabetes type 1 always require insulin. Let's review now some of the gonadal and placental hormones, meaning those hormones that come from the gonads, the testes, and the ovaries. The importance of these is to remember that the gland that controls them is the pituitary gland. And the pituitary gland produces two hormones, FSH and LH. And both, they will have, the targets are the same. So the gonads, in this case, if it's the female, the ovaries, if it's the male, the testes, but they're going to do something different. So LH, for example, in a male is related with production of testosterone, which I'm going to show you next. And that's what we we're going to cover in the next slide. The hormone that you need to study for your exams is testosterone. This is the hormone that comes from the testis. Don't worry about this one too much. Testosterone is a hormone produced by the males and the testes, but in order for your body to be able to stimulate the testicles, it follows that hypothalamus pituitary axis. So the hypothalamus stimulates the pituitary gland, and the pituitary gland releases the two hormones FSH and LH. Now, in terms of testosterone, the one that we need to remember for a male is LH, because LH is the one that is going to stimulate the cells in the testes to produce testosterone. Don't worry about those specific cells at this point, because when we review the reproductive system, we're going to learn them. At this point, don't worry about it. You're not going to be asked about those cells at this point. So just know that LH in a male is the main trigger or stimulus for the production of testosterone. And what you need to know about testosterone is the function, okay? So testosterone is the male hormone, is the hormone that is responsible for the secondary development of the secondary sex characteristics. So that means that is the hormone that makes a male be physiologically a male, like increased muscle mass, the changes in voice that typically occur during puberty when the testosterone levels go peak or go high, and there's also that body hair distribution. Testosterone is also crucial and important for maturation of sperm cells. Now, so for this, when we in the testicles, when the sperm, which the sperm is the gamete, is the reproductive cell, right? The process of making new ones is called spermatogenesis, and as you will see, you need testosterone for a healthy spermatogenesis, but also you need FSH, follicle stimulating hormone, that will stimulate cells that also support spermatogenesis. And there's another situations in the clinic. There are testosterone shots. If a male is taking testosterone shots, that means that they are not producing enough in the testicles. They're not producing enough testosterone. A male with lack of testosterone will have will have problems with sleep, low energy, muscle mass, even the bones will be affected, even the blood. So they might have to use testosterone shots to replace that. Now, you will see sometimes something that is interesting, and is not, I hope it doesn't surprise you when you see that, because again, you're learning this now. Sometimes you will see females in doctor's office receiving testosterone shots. And you might say, well, how come, right? Well, testosterone in a female increases libido or sex drive. So some females will use testosterone for that, or other females will use that, to gain muscle mass. But most of the time in the clinical setting, you're going to see in a female using testosterone when they're having, it's used for sex drive and for that. Also, during the pregnancy, there are some females that will say that when they're pregnant with a boy, the testosterone some way generates this sex drive, and there's something that some patient will express versus being pregnant with a female. Right, with the ovaries, you need to know two hormones that are produced by the ovaries, estrogen and progesterone. The details about these hormones and their functions are going to be covered more in the reproductive system. Estrogen and progesterone, they target several organs, but also the uterus. So, for example, when the levels goes down, that what triggers is the menstrual cycle, the bleeding. But again, at this point, the main function you need to know is about estrogen is the equivalent to testosterone but in a female. So estrogen is the hormone that is related to the development of the secondary sex characteristics. Also, estrogen, again, they follow in order for you to stimulate the ovaries, you will need FSH and LH, right? FSH is the name of this hormone has to do more with the ovaries, right? Because in the ovaries we have the egg, which is the sperm cell in a female, but that egg uh, is kind of wrapped in a follicle, and the FSH is a hormone that stimulates this follicle to grow. That's why it's called follicle stimulating hormone. The cells that form this follicle, when they mature and they're big enough, are the cells that are going to produce these hormones, estrogen and progesterone. Also, LH in a female, important for your exams, is the hormone that is related or associated with ovulation. Also, LH stimulates these cells to produce estrogen as well, but the most important you need to know is ovulation. Okay, ovulation, LH. Ovulation is the fact of the egg being released from this sac, and then the egg exit the ovaries. Um, Progesterone at this point, I will say that the most important thing that you need to know at this point is the importance of progesterone during pregnancy. This is the hormone that maintains pregnancy. So when somebody has uh, a bleeding and is pregnant, with a female is pregnant, is bleeding, and there's a chance for miscarriage, sometimes you will see the patients receive progesterone shots. So if somebody is getting progesterone shots, you know now that they're trying to save, that pregnancy, prevent miscarriage. Because again, when a female is pregnant, this is the hormone that will keep or maintain pregnancy, progesterone. Important to remember that because it's in one way or another related to this hormone that comes from the placenta. Okay, the placenta has this human chorionic gonadotropin hormone, which first is the one that turns your test positive, the urine test, when somebody wants to find out if it's pregnant or not. The concentration, okay, of this hormone rises, and this is specific from the placenta. So if it's high, that means you're pregnant. But the purpose of this hormone is not to let you know that you're pregnant. The main function of this hormone is to promote, okay, is to keep the ovaries producing progesterone. In some point, when the placenta is still, in development, when this is not it has not developed enough yet to make their own progesterone, the human chorionic gonadotropin hormone is the one that will keep the ovaries producing progesterone. Later, when the placenta becomes big and mature, the placenta will be the main place where progesterone will be produced. The last hormone here is called relaxin, and relaxin is a hormone that, as the name implies, is supposed to relax your skeletal muscles prior labor, and facilitates the relaxation of those muscles and ligaments to prepare the body for labor. Okay, let's review now those organs that has a secondary endocrine function. Now, just the fact that they're at the last, that doesn't mean that they're less important. In fact, they're pretty important. So, before we move forward, let me just tell you this very quickly. If I were you, and I'm thinking about the things that I'm going to see more frequently and in real life situation, I will become expert in thyroid gland. I will become expert in pancreas, making sure that I know the hormones, how they work. After that, I think another important here to know, let's see, yeah, I will say these, you know, these two also, they're pretty important, pretty frequent. Now, the other ones, the pineal gland, pituitary gland, parathyroid, adrenal gland is important. But the other ones, it's not that they're not important, it's just that the disorders are not that frequent. And you might not see or medications or treatment that are associated or related with that in order for you to understand why they're receiving that is less common. So I will, you know, uh, I will just prioritize here. You know, thyroid, endocrine pancreas, uh, the testosterone, progesterone especially, and pregnancy, and these organs, the secondary organs that we're going to mention now. Okay, so in the chest we have two organs here we mentioned before, the thymus and the heart. The heart is a secondary organ. The thymus is, if you look at closely this picture, is this gland is right on top of the heart. And as I mentioned before, students confuse that with the thyroid gland. Location is important. Thymus is in the chest, thyroid gland is in the neck. So if you see a gland right on top of the heart, that must be the thymus. Okay, so in this table I have those two organs and the hormones they produce. With the heart, we have this ANP, which I mentioned briefly a minute ago. When we were talking about aldosterone ADH, I'm going to talk about that in just in a minute. And the thymus, that gland is important because it produces this hormone, thymosins. And thymosins are the hormones that will affect these cells called lymphocytes, but specifically T lymphocytes. That is the key. T lymphocytes are the most important cells of the immune system. Okay, so it's the most important cell. Your immune system is what protects you against infection and fights pathogens, right? HIV, AIDS, targets or destroy T lymphocytes. You know, people who has AIDS and HIV, the reason why they die is not because the virus itself, is because the other diseases they get after, because their immune system is so weak, that's what kills them. But the reason why their immune system is so weak is because destruction of this specific cell, which is again the most important one. Now, if we look at the entire immune system, which we're going to review in chapter 21 and in future classes, you have two types of lymphocytes that are very important. Lymphocytes, and just this is a quick recap, where those blood cells are produced. All your blood cells, where is the place where blood cells are produced? Do you remember? Is the bone, specifically the bone marrow. Is the bone marrow in the compact bone? No. The bone marrow, red bone marrow, is in the spongy bone. So there is where we have all the blood cells. What are the blood cells? Red blood cells, platelets, and white blood cells. In white blood cell, we have several types. I'm not going to describe all of them yet here. I'm just going to tell you that the most important ones are lymphocytes. Lymphocytes, you have two types. Lymphocytes B, or B cells, or B lymphocytes, and T lymphocytes, or T cells. Right? The same thing. If you see T cells, B lymphocytes, T lymphocytes, the same thing. Now, why they're called T while they're called B? It's because when they're produced by the bone marrow, they're still immature. They're still not able to do their job. They're not completely mature. So they need to go through a process of maturation. And in this case, B cells are the ones that are going to produce antibodies. They mature in the bone marrow. So because they mature in the bone marrow in the same place where they're produced, that's what they're called B. Now, these lymphocytes that mature or gain all the features they need to fight bacteria or infections in general, they mature in the thymus. That's why they're called T lymphocytes or thymus. With the heart, when the blood pressure is too high, or when the volume, when you have overload of blood volume, that of course affects your blood pressure. Who is the pump of the body? The heart. So the heart is, when you have an excessive amount of fluid or blood pressure, the heart is like, hey, give me a break. You need to chill out. So when the blood pressure is too high, that stretches the walls of the heart and stimulates the heart to produce this hormone called ANP. ANP It stands for atrial natriuretic peptide. Again, if you break down the word, it will help you to remember for the long term. Atrial refers to a specific part of the heart called the atrium. So the heart has four chambers, two superior and two inferior. The superior chambers are called atria. So atrial tells you that the cells that produce the hormone, they're located in the atrium, okay, of the heart. Natriuretic. So hopefully you remember that ADH, antidiuretic. So uretic, right? That means urination. Uh, that means diuresis or so. And what is that urination? Well, this natri. What does that mean? So when you and that has to do this part has to do with sodium. I'll tell you, when your sodium levels in blood, when the sodium in blood is high, it's called hypernatremia. If the sodium levels is low, it's called hyponatremia. So natriuretic and tremia, okay, has to do with sodium. So it's telling you that this hormone makes you urinate sodium, okay? Oh, urination. So this hormone makes you urinate sodium, and we just said that if you get rid of the sodium, water follows the sodium. So back again here, when ANP reaches the kidney, it stimulates or prevents sodium reabsorption. So basically, your kidney are not going to, so I'll make this arrow pointing down to symbolize that there's a reduction. That was too crazy. Okay, so there's a reduction of sodium reabsorption. Um, and if you do not reabsorb sodium, that means that sodium is going to the urine. And again, what happens with sodium? Water follows. So less water is being reabsorbed, so less sodium and water reabsorption means that you're going to lose them through the urine. And what happens when you lose water through the urine? You urinate, or let's put here, you produce more urine. Okay, so basically, and again, what happens if you're losing water? Your blood volume will go down and your blood pressure will go down, which is precisely the reason why the heart releases that, right? Basically, ANP works as an antagonist of aldosterone. So ANP do exactly the opposite of aldosterone. Aldosterone increases the sodium reabsorption and water reabsorption to increase blood pressure. ANP inhibit or reduce sodium and water reabsorption to decrease blood pressure. And don't forget ANP, but ANP again stimulates water reabsorption directly. So independent of sodium. Okay, the other two organs with the secondary function, the kidneys and the small intestines. Let's look at them. Okay, with the kidneys, I'm not going to repeat renin because we already talked about it, and at the end, just that renin is going to be in the long at the end associated with the release of aldosterone by the adrenal glands to bring your blood pressure down. So I'm not going to talk about more about that. But another new hormone released by the kidney is erythropoietin. So this one, yes, I'm going to talk about that one for sure, is very important in several settings. So when you're first, we need to think about the importance of oxygen. Oxygen is a big thing, right? I mean, all your tissues, your cells, they need oxygen. what are the cells that transport oxygen in your blood? Red blood cells. Those are the cells that carry oxygen and deliver the oxygen to your tissues. So when the oxygen levels drop, either because you're having a hemorrhage, because you're having anemia, or you're not breathing enough, or you're living in a place that has high altitude and the oxygen is low, it doesn't matter. If the oxygen levels in your blood is low, your kidneys are detect that. The kidneys detect that and they produce, they're the only organs that produce erythropoietin. Erythropoietin, we're going to learn in the next class, the name for red blood cell is erythrocytes. And you need to get familiar with erythrocytes. The hormone that stimulates the production of erythrocytes, erythropoietin. Erythropoietin, we said, target what? The bone, right? Specifically, the bone marrow to produce uh, red blood cells, okay, to produce red blood cells. In other words, your bones will not produce red blood cells if they don't have erythropoietin. What is the clinical relevance of that? That we have erythropoietin injection. When do we use that? In people, patients who have kidney insufficiency, or the kidneys are not longer working, people who are in dialysis. Those people develop, or people have chronic kidney disease, severe stage of end-stage chronic disease, their kidneys do not produce erythropoietin. What happens when you don't have enough red blood cells? You develop anemia. Or again, if we talk about diabetes mellitus, right? Problems with high sugar levels and problems with insulin. One of the complications of diabetes, which is extremely common together with hypertension, common diseases that affect many people, is that high levels of sugar in the long term will damage your kidneys and you're going to develop diabetic nephropathy. And if it's severe, the kidneys are going to, they will stop doing their job and they will stop producing erythropoietin, and that will lead to anemia. So pretty high yield to know. Also, erythropoietin is something that, when we talk about humans and cheating, there are a lot. So athletes, sometimes they use erythropoietin to cheat on competitions. All right. How? Well, just think about when you are running, when you're doing highly demand exercise, your muscles are requiring a lot of oxygen because they are need energy to contract. So if you inject yourself erythropoietin, you're going to have way more red blood cells than other people who are not receiving this injection. And if you have more red blood cells, you have ability to carry more oxygen. That means that your endurance and um, you're going to resist more time and for more period of time without fatiguing your muscles than somebody who doesn't. So uh, erythropoietin, EPO, is something that is prohibited, right? It's against ethics that athletes will use that. And in fact, there were famous, cases in which they found out that somebody was using that, and he was a championship, and they revoke all his trophies because he was using erythropoietin during this competition. So now erythropoietin increases red blood cells. The other gastrointestinal, small intestine, I'm going to explain that in the next slide. So I'm going to explain this very quickly because I already told you that, just in case that you're visual, you'd like to see that. So when your oxygen levels drop, okay, that low levels of oxygen in the blood will be detected by the kidney. The kidney responds to that by secreting erythropoietin, which targets the bone, specifically the bone marrow. And erythropoietin specifically will increase or will stimulate the production of red blood cells. I'm saying it specifically because erythropoietin do not stimulate the production of platelets or white blood cells. You have other hormones that do that. So that is the way, as you can see here, through erythropoietin, how the kidney, the bone, and the blood cells, red blood cells, are related to each other. All right. I know probably you're tired at this point. We covered and went through a lot, but this is also important to know. These two hormones, the hormones we're going to learn, they're called secretin and CCK cholecystokinin. Okay, cholecystokinin. These hormones are produced by the small, I'll put here S for small, intestine. So what we're seeing here is the small intestine. And the organs, the target organs that are important are going to be the pancreas twice and the gallbladder. So I'll put GB for gallbladder. Those are going to be the target organs. Now, when the pancreas will produce bicarbonate and when the pancreas will produce pancreatic juice, in which part of the pancreas we're talking about? Is this the endocrine pancreas or exocrine? So this is actually the exocrine. Okay, so the exocrine pancreas, because these substances are going to be uh, secreted into the duodenum, into the small intestine, and not into the bloodstream. So we're talking about the pancreas, digestive function of the pancreas. So to go through the functions of these, we need to think about digestion. Again, this is something that we're going to learn in detail when we cover digestive system, but it's important to have just a general idea. So what we need to do here is to represent the stomach, because the stomach was removed. When you eat something, food, you know that there are three major components of the food. What are the three major components of the food that we need to break down to be able to absorb and digest? Proteins, fats or lipids, I'll just put fats, and carbs or sugars, right? I'll just put carbs. Those are the three major things. Now, the process of breaking these down to the smallest component is what we call digestion, okay? So you need enzymes to be able to break down proteins, you need enzymes to break down fats, you need enzymes to break down carbohydrates. These three, when you eat in your stomach, the thing that your stomach produces is acid and an enzyme that is activated by acid called pepsin. This pepsin breaks down proteins into amino acids. About 80% of the protein digestion take place here in the stomach. However, the fats and the carbohydrates, they're not digested at all. So they're undigested. Your intestine nothing will be absorbed if you don't break those down. So at this point, with the acid, now the food is mixed with acid here, is very acidic. 80% of the proteins at this point has been breaking down into amino acid. They're ready to be absorbed. However, the stomach, because I just mentioned acidity, is the only organ here that is designed to tolerate that acidity. How do we neutralize an acid? We neutralize an acid using bicarbonate. Okay, just keep that in mind. Bicarbonate is something that we use to neutralize acids. So when the stomach releases that chyme, chyme is the term for food mixed with acid. That chyme, this first will come here to this duodenum, to the small intestine. In the small intestine, you have some glands that will produce bicarbonate itself to prevent the acidity from destroying or damaging the intestine, but it's not enough. So the amount of these glands produces is very minimal. So what your intestine needs is a large quantity of bicarbonate to neutralize that acidity. The small intestine will produce secretin, will really produce this hormone. Secretin will travel to the blood, will reach the pancreas, and then the pancreas, in presence of secretin, the cells will start producing bicarbonate, and then through this duct, which is called the pancreatic duct, all the bicarbonate you need will be delivered here, and that will neutralize all the acid. I'm going to move this here. So now we have here a lot of bicarbonate that now neutralize the acidity. So the job is done. Okay. Now remember that at this point, now the acid has been removed. you have 80% proteins that are digested, so you still need to digest, you need to break down 20%. You need to digest 100% of the fats, and you need to digest 100% of the carbohydrates. So, but in order for the intestine to do that, they have to neutralize the acid first. Next, then, the small intestine is ready to digest. The small intestine will produce CCK, and CCK stimulates or target two organs. Okay, the first one, or both here, gallbladder and the pancreas again. Okay, so the pancreas again. In the gallbladder stores bile, right, as you know. So the bile in the gallbladder will contract in presence of CCK, and will secrete this bile into the small intestine. We need bile in order to break down fats, so that's why we need that bile. But also CCK will stimulate the pancreas, and the pancreas in this case, what it's going to produce is pancreatic juice. So see how the cells of the pancreas, depending on which hormone you use, they respond differently, right? So in this case, pancreatic juice. What is this pancreatic juice? Essentially is a cocktail of enzymes, and enzymes that breaks down all the three components. These enzymes in the pancreatic juice can break down proteins, can break down fats, and can break down carbohydrates. So all these pancreatic enzymes or juice will be delivered here, and then they will break down all the components. Digestion will be complete, and finally your intestine will be able to absorb those nutrients that you then can use to what your body needs to do with them, right? In case of amino acids, to build their own proteins. In case of fat and carbohydrates, to use them as a fuel. There are other additional hormones, adipose, liver, and skin. Just read about them. We talk about vitamin D and how this is related with calcium. Just read about them, okay? Now, this is also that you might be asked in the quiz about the bisphenol A. This is a chemical. I'm just going to briefly, I'll let you read. If there's not a hard reading, it's easy if you just read. It's a chemical that is used in hard plastics, okay? So, there are people who um, they tend to use a microwave, and they will heat food or drinks or whatever that are contained in plastics. And if those plastics contain bisphenol A, the microwave, the heat, can cause that this bisphenol A gets released in whatever you have in that container. It could be, in the food, or it can be in the liquid. The thing is, this chemical, bisphenol A, affect your endocrine system. It can negatively impact the production of hormones. So there are cases where you have hormonal dysfunction and all that because this bisphenol A. Now, in the United States, there are still containers that contain bisphenol A. The way how you can see is when you look at the bottle, when you look at something that is a plastic, they have a sign, they have like a number, and it looks kind of like this, okay? So they have a number. If in the bottle says 3, or if it says 7, that tells you that that plastic container contains that chemical, and therefore you shouldn't heat food or put food there while you use, to heat in the microwave, because that means that will release that bisphenol A into your food. All right, we are done. You made it. I made it too. Well, the next step is to recap. So watch the video again, because I'm not going to recap with you. You just go back, study early for this. I know that was a lot. The two parts, 1 and 2, is about 4, almost 5 hours. And I told you before, this class normally takes 2 in-person classes to be completed. There's a lot of content, and that's why this is the hardest part, one of the hardest concepts and one of the harder exams for the lab and lecture. All right, I'll see you later.